Thank you very much. I'd like to thank Professor Knecht and his scientific and planning committee for inviting me. I think this is a wonderful opportunity for dialogue between our various specialties. I'm going to, the topic of primary radiochemotherapy is certainly a large one. And as you see here, we've come a long way, particularly in the last decade, in establishing various standards of care and clinical situations where concurrent chemoradiotherapy is viewed as a standard of care. And you can see I list some of the randomized trials here that support concurrent chemotherapy use in these clinical situations. We could spend a whole day talking about this. I'm going to make comments on larynx cancer and review the 9111 data and where we're going with that. I'm going to make some comments about oropharynx cancer, particularly related to studies that are in development. Now, I think that for locally advanced disease, we can say that our standard of care options to preserve the larynx include conservation laryngeal surgery in selected cases and places certainly where there is the expertise to do this type of surgery, concurrent radiation, standard fractionation radiation, and cisplatin 100 milligrams per meter squared for 3 doses, and radiation therapy alone. Let's go through the studies, the data that supports that. This is the VA Laryngeal Cancer Study Group data published in 1991, which I'm sure everyone here is very familiar with. This study compared induction cisplatin for 3 courses, cisplatin 5-FU for 3 courses, and in responders, radiation was used to preserve the larynx. This was compared to the standard laryngectomy followed by postoperative radiation therapy. And the study showed no difference in survival with follow-up out beyond 10 years. The larynx was preserved in 64% of patients at any point along the curve. The 2-year laryngectomy-free survival rate was 41%. That was actually more recently published by Dr. Wolf. The pattern of failure did differ between the 2 arms. We know that in the chemotherapy-treated arm, there was significantly more local failure, local regional failure, than in the surgery arm. However, there was a reduction in distant metastatic rate in the chemotherapy arm compared to surgery. The risk factors for needing laryngectomy were T4 or N2-3 disease, and of note, 56% of patients with T4 cancers ultimately required laryngectomy. So that trial was followed by the intergroup RTOG 9111, which I and my colleagues published in 2003, and this was a study designed to look at 3 non-surgical treatments and determine of these 3 treatments which would have the best outcome in terms of organ preservation and survival outcomes. So this is identical to the VA induction chemotherapy arm, our radiation and concurrent cisplatin, and radiation alone, all using standard fractionation radiation. And the study differed from the VA study in that the high-volume T4 patients were excluded, those with tumor penetrating through cartilage into soft tissue or with tumor invading further than 1 centimeter into the base of tongue. The feeling was that these were not appropriate candidates to be treated with radiation therapy alone. The study also differed by having a planned neck dissection for N2 and N3 disease patients at initial staging. This shows you the patient characteristics. So about 70% supraglottic primaries, nearly 80% T3, and about 70% N01, 2/3 stage 3. So clearly, this is an ideal population to compare directly to radiation therapy alone, and one could say an intermediate stage population. And here are the results summarized in terms of larynx preservation, and you see the green line is the concurrent chemoradiation treatment, the yellow, the induction arm, and the orange, the radiation alone arm. And there was a 43% absolute reduction in laryngectomy rate with concurrent treatment, with the other two treatments running quite close together with no significant difference in the induction versus radiation comparison. Could we advance? Please, thank you. There was no difference in survival, however, between the three treatments, 76% at 2 years. This shows you local regional control. Again, that same pattern with superiority of local regional control in the combined concurrent treatment arm and no difference for the induction versus radiotherapy. Here you see somewhat of a different picture, disease-free survival and laryngectomy-free survival. And you see now that there is separation between the arms with significantly superior outcome for concurrent treatment versus radiation in both of them, with the induction arm in the middle, but not different from the disease-free survival in a statistical comparison, and with a trend for again significance between induction and radiation alone, and no difference between the two chemotherapy arms. It's interesting to look at response and compliance after 2 cycles of induction chemotherapy. So 85% of patients had complete or partial response at the primary site. And per protocol, if one did not have a partial response, then laryngectomy was to be done. And you see that in this small group of patients, which constituted 15%, only 29% had laryngectomy per protocol, 25% had other or unknown treatment, other chemo or unknown treatment, and nearly half of the patients went on to radiation therapy with or without additional chemotherapy, and all of those patients achieved a complete response post-radiation with 1 late failure. So I think this tells us that if we're going to use induction radiation to select patients as a surrogate biomarker for sensitivity to radiation and a good outcome, we may be jeopardizing potential for organ preservation by sending those patients on to surgery. It's not a given that those patients are not going to have a good outcome from subsequent radiation or in the future chemoradiation. Other findings: chemotherapy in both treatment arms suppressed metastases. Chemotherapy added toxicity, substantial toxicity. So whether one received chemotherapy as induction or as concurrent treatment, the grade 3-4 toxicity, 81%, 82% versus 61% for radiation alone. Overall, laryngectomy was required in 25% of patients. You can see 16% in the chemoradiation group, 28% in induction, and 32% in radiation. So when I discuss this with my patients, I tell them that the survival is the same, but that you have a greater chance of requiring at some point in time laryngectomy if they undergo radiation alone versus the combined treatment. We also looked at quality of life and function assessments. There was no difference in speech at 12 and 24 months. And you see here, if we define it as moderate impairment, unable to be understood on the telephone or worse, no differences at those intervals between the three arms. For swallowing function, at 12 months, we did see a delay in recovery with concurrent treatment. You can see 23% were limited to soft foods or liquids only at 12 months compared to the other groups. No difference, however, at the 24-month time period. Now, we will be presenting a 5-year update at the ASCO meeting. I can tell you that that update will confirm the 2-year analysis in that there's no significant difference among the 3 treatments for survival. Function continued to be excellent without difference, as you might expect, given where we were at 2 years. Concurrent chemoradiotherapy is significantly better than radiation for all the endpoints except for overall survival. Induction was not better than radiation alone for larynx preservation and local regional control. Concurrent chemoradiation and induction, both now, are better than radiation alone for laryngectomy-free survival and disease-free survival. The analysis is not yet complete for 3 very important outcomes. One is late effects. The second is site of first failure, and the third is cause of death. We did see in the 2-year analysis that there were significantly fewer deaths from larynx cancer in the concurrent chemoradiation arm, but there were more deaths from unrelated causes to the cancer. So prior to the ASCO presentation, we will have determined those outcomes. So I think the implications for patient management for larynx preservation of T3 and low-volume T4 disease is that chemotherapy and radiation should be given concurrently. For the high-volume T4 disease, for glottic cancers or penetration through cartilage into soft tissues, we would recommend surgery. And for supraglottic cancers where there's extension, bulky extension up into the tongue base, I think there is this option for concurrent chemoradiotherapy, although that hasn't been directly addressed in a dedicated larynx study. Radiation alone should be the treatment for patients unable to tolerate added toxicity of the concurrent chemoradiotherapy, and no role for induction chemotherapy outside of a clinical trial. Now, concepts in development. I think what we're headed towards is separating intermediate from more advanced stages with survival as the endpoint. Radiation with biologics such as EGFR inhibitors or angiogenesis inhibitors is under discussion within the cooperative groups. And for the more advanced, then adding a biologic, again, such as an EGFR inhibitor, to the cisplatin standard fractionation radiation, or looking at induction followed by cisplatin and radiation. Other questions that I want to touch on, alternative chemotherapy regimens, the impact of changing epidemiology with human papillomavirus now and the prevalence of the increasing prevalence of oropharynx cancer. Are we seeing a therapeutic effect with some of the superb results that we're reporting with oropharynx cancer, or is this really a different disease and perhaps a patient selection? And I'll show you what I mean by that on the next slide. So I know you can't read this, and I apologize for this study, for the small print. This is a ECOG study 2399. This is a study where we looked at induction carboplatin Taxol for 6 weeks, 2 cycles, followed by weekly Taxol with standard fractionation radiation, so single-agent Taxol. And we enrolled patients with resectable stage 3 for oropharynx or larynx cancer. And next slide, please. And here you see treatment delivery. So we were successful, very successful in delivering the 2 cycles of induction treatment to nearly everyone. There were 36 larynx cases and 69 oral pharynx cases for a total of 105 in the study. When we got to the concurrent